Today's presentation is on the evolution of U.S. healthcare delivery policy, and this will be delivered by Dr. Robert Kulesher. Dr. Kulesher is an associate professor at East Carolina University in the College of Allied Health Sciences. He is in the Department of Health Services and Information Management. He is a health policy specialist and has written on the impact of health legislation on providers. Robert's research interests include national health policy, healthcare financial management, healthcare of the poor and uninsured, health insurance, Medicare, and Medicaid. His research focus is on the impact of Medicare reimbursement on healthcare providers. Prior to coming to ECU, Dr. Kulesher held faculty appointments at Penn State, St. Joseph's, and Rutgers universities. He attended Villanova University in Pennsylvania, where he received a BA degree in psychology. He received the Master of Health Administration degree from Washington University in St. Louis. After a 20-year career in healthcare administration, he earned a PhD in urban affairs and public policy at the University of Delaware. Please join me in welcoming Dr. Robert Kulesher.
A lot of that I wrote, particularly the 20 years experience. Now I feel old. This is a interesting topic to me, and the way I'm going to go through it today is a way that I kind of was presented to it by myself and my own research. I was always interested in how we got here with our current state of healthcare policy at the government level and also at the political economic level as well. While there are many definitions of health policy and many different avenues that we can go down, I've chose to focus on a few, and I'll bring that to you gradually as we go through this. I was really interested in the early part of the country's development and the health policy of the time and how that has actually influenced our current situation. So while we're looking at a picture of a naval hospital, think government influence, think military, and this slide will occur again towards the end of the presentation, and you can see why I think we have come full circle and all of that. Just a little bit of background of the policy, the history of how we handle healthcare. It's a derivation of the English Poor Laws, where we were taking care of individuals, deserving individuals who had fallen on hard times. The English Poor Laws span several decades, and obviously, with our early history in the United States, we drew a lot of our policies from that, care of the poor, and also taking care of laborers. We're not at the Industrial Revolution, and a lot of manpower is needed for commerce. And also the Poor Laws also created almshouses, and almshouses eventually became some of the first hospitals, not only in Europe, but also in the United States. And the example I use is Blockley Almshouse in Philadelphia, which later became Philadelphia General Hospital, which was a hospital owned and operated by the city of Philadelphia, which actually went out of existence in 1977, a sign of our times of the public or the municipalities with their budgetary problems getting rid of services they think the private sector can handle. The early hospitals in the United States are called the Marine Service Hospitals, which is a series of hospitals at the seaports to take care of sailors and merchant marines who are coming in and out of the ports of America. And the reason for the hospital is twofold. One is to take care of workers who are ill, and two is to quarantine people and keep them separate from the general population to prevent the spread of disease. And this is a throwback to what was happening in Europe, in France, with Louis XIV establishing a home in Paris for the aged and unwell soldiers, and later Greenwich Hospital in England for the same reason. In 1730, before we were the United States, Britain taxed any and all seamen coming in and out of U.S. ports 6 pence per month to support the Royal Hospital in Greenwich, England. And then later, when the young U.S. nation, John Adams signed into a law and act for the relief of sick and disabled seamen, and in our customary and usurious way, it became 20 cents per month deducted for care of sailors and Marines. Now, we're not talking so much of military, we're talking about merchant Marines at this point. And the medical care that they provided, they didn't have any hospitals, obviously, from the get-go, so they were under a private contract with providers of health care at private hospitals and physicians. So in this act, an act for the relief of sick and disabled seamen, it set up the law set up the precursor for the U.S. public health system of marine hospitals, or public health hospitals. The marine hospitals was the early name, and it wasn't military marine, it was maritime. And then eventually became the U.S. Public Health Service and the U.S. Public Health hospitals that we had in many of the seaports in the United States. President of the United States appointed directors of the Marine Hospital Service. Here's the one in Chelsea, Massachusetts. One thing I forgot to point out in the English Poor Laws, the law is this line here. The law stipulates that parents and children were responsible for each other. I kind of thought that was common sense, but I guess we had to have that law back in the early part of, or right after the Middle Ages, and it's still intact today, I think. At least I hope so. Anyway, so we have this law and this mechanism for developing a hospital system under this particular law. Any excess money collected from the Marine Hospital Service would go towards the purchase and the construction of other hospitals as well. The so-called first Surgeon General of the United States was actually appointed supervising surgeon of the Marine Hospital Service, a graduate of the Chicago Medical School, which later became part of Northwestern University, and was medical director of the Army of Tennessee of the United States Army. And after a tour of hospital practice in Berlin and Vienna, upon returning to the United States, he was appointed supervising surgeon of the Marine Hospital Service. Some of the challenges that the Marine Hospital Service had is who is covered by the service, by this health care plan. And just listen to just listen to this rhetoric and see if it rings true today. There are many questions regarding qualifications for hospital admittance. Had the sailor served long enough? Were lake, river, or canal mariners subject to the tax and entitled to care? What about unemployed sailors who had previously paid taxes? Despite the occasional promulgation of national rules under various Treasury secretaries, such questions were most often decided locally. It's a local interpretation of national laws. Policies fluctuated depending on the port location and the whims of the collector or surveyor in charge. Tax collection was so uneven, often insufficient to meet local health care costs. Such funding shortfalls contributed to the low or non-existent levels of care that existed in many communities during the fund's first 3 or 4 decades. And this is an article written by John Jensen, which was published in the Public Health Reports in the 20th century. Despite problems, the Marine Hospital program stumbled along and grew from a handful of federal hospitals in 1920 to about 24 government-built hospitals by the eve of the Civil War. In addition, thousands of mariners received care through Marine hospitals. Marine Hospital Fund contracts with local physicians, city hospitals, almshouses, and charitable hospitals and organizations run by religious organizations. So at the same time that we have the Marine Hospital System, which is our first national system of hospitals, the private sector was developing their own hospitals, and some of the more famous ones that are still in existence today is the Pennsylvania Hospital, New York Hospital, and Mass General. It's interesting to note Mass General, this is their admission policy for their first year in 1821. And this is a notice put in the newspaper by then superintendent of the hospital, Nathaniel Fletcher. Public notice here, having been given that the General Hospital in the North Allen Street, Boston, which is now called, Mass General, will be open for the reception of patients on this day, September 1. I have been directed by the visiting committee of the hospital board of directors to give this notice, that applicants from patients must be addressed to the visiting committee and lodged with me, the superintendent, at the hospital. Upon receipt of such application, the physician or surgeon of the hospital will visit the patient at his or her residence to determine that the person be in a suitable object of institution, and that not be afflicted with any contagious disease. In other words, they're screening out patients if they're diseased or have an infection. They don't want to bring them into the hospital community where it would run rampant. In the case that the patient resides outside the city, written application for his or her admission must be accompanied with a certificate from a respectable physician of that particular neighborhood that the person is free of disease or of a communicable disease. So what are they treating in the hospital? If we're ruling out a good bit of infectious diseases and diseases of unknown origin, they're looking at people that need surgery or that, from a physician standpoint is not harboring a communicable disease. I would imagine many people with communicable diseases were admitted under that situation. What I did is looked at about 30-some pages listing various laws and events that impact healthcare delivery in the United States, and came across 61 that seemed to be pertinent to healthcare delivery. And my intent was, I'm going to look at this from a public health standpoint, then I'm going to look at them as which ones created a health benefit, and then which ones created a demand for healthcare. And out of 61 of these laws and events, 14 were centered around public health, 22 around health benefit, and another 22 around a demand for health care. And then upon closer inspection, health care benefit and demand for health care were very similar list, and certainly that makes sense. We already talked about taxing of the American seamen before the United States was incorporated. And then in 1776, we have a Pension Act, an act providing compensation to soldiers. This is our first disability insurance law and policy for soldiers of the Revolutionary War. 98, again, we're looking at the Act for the Relief of Sick and Disabled Seamen, developed a federal network of hospitals. And then we kind of jump through the 19th century to the 20th century, and we're looking at War Risk Insurance Act for medical services to veterans. So what we're doing is we're concentrating on our soldiers and sailors who have war injuries and other disabilities from serving their country. In 1921, the Shepard-Toner Act enacted and provided grants to states to develop health services for women and infant children. This is the first of, well, you might want to say is a precursor to Women and Infant Children, WIC, and more recently the Children's Health Insurance Program, which was enacted in the past 10 years. So there always seems to be a shall we say, a soft spot in the legislature and in the community interest for women and children. But upon looking at this law a little bit closer, there is some discussion in the literature that this law also had a very practical purpose. What happened is in World War I, as people were being enlisted for military service, a lot of them still were harboring childhood diseases or were suffering other ailments, from that were based in childhood diseases or lack of vaccination. So this particular act, Shepard-Toner Act, was an attempt to vaccinate and take care of infants and also mothers so that we have a healthy population next time we have to go to war. Very, very practical way of looking at it. However, this particular law was rescinded in 29 due to a sense that it was perhaps linked to socialism, that healthcare should be a private matter. And in this country, that's always been a debate and in a sense that healthcare is a private matter. We don't want government influence, and that's influenced by two strong vectors. One would be the American Medical Association and other related organizations where physicians are trying to control their own economic situation. The second is the American philosophy of rugged individualism, which still persists today, even though the West has been settled, and but the idea that health is a individual responsibility is still very strong in many parts of the country's conscience. To continue on, we're looking at what we're looking at here are laws and events which create demand for health care. 1921, we're looking at the Indian Health Division was created, later the Indian Health Service. 1929, first Blue Cross plan was established. That's not a federal program, but it is a significant event in health delivery development. 1935, Social Security Act was enacted. What was not part of the act was national health insurance, which was actually part of the discussion for several years prior to enactment of the Social Security. And another thing to remember about the Social Security Act, it is the act upon which Medicare and Medicaid was built on. Medicare and Medicaid are amendments to the Social Security Act. Creating the demand for health care continues. 1941, Nurse Training Act. 1946, Hospital Survey and Construction Act. We're giving money to hospitals and to communities to build hospitals where there are none. We're expanding capacity. We're putting federal money into the private sector to increase our capacity to provide health care. 1950, National Science Foundation establishes autonomous entity which provides federal support for university-based research, and that should be physical, not physician, physical, medical, and social sciences. In 1962, we started the Migrant Health Program, still in existence. And you can see there's this, through this and other laws, there is this propensity to build capacity for the healthcare system of our country, both private and public. In the mid-60s, Allied Health Professional Personnel Act for support for training of allied health workers. 1970, National Health Service Corps was enacted to provide medical and other health services to the medically underserved areas in rural America as well as urban America. Health Insurance Portability and Accountability Act, HIPAA. State Children's Health Insurance, which I had mentioned. Medicare prescription drug in 2003. Medicare Part D, a new level of an additional benefit to the Medicare program. And then the Affordable Care Act, which we're bantering now at the Supreme Court level, whether or not that is going to pass either in part or its entirety. So, in looking at all these different laws, as I went through looking at public health and health, creating a health benefit demand for health care, I'm looking at this and I said, well, there's regulation, there's cost control, and there's commerce. And so I was kind of, curious about how does that fall out. So I went back and looked at that. And in addition, I saw there's 25 pieces of legislation that created agencies where there wasn't before. So if you look at the growth of agency, again, we're going back to the colonial period. A significant, a historical note in 1862, when the president appoints a chemist to serve in the Department of Agriculture, which it was the beginning of the Bureau of Chemistry and the forerunner to the FDA. I mentioned the appointment of the first Surgeon General. 1887, federal government opened the hygienic lab on Staten Island for research on disease. This is a forerunner to NIH. 1891, Marine Hospital Service assigned the responsibility for medical examination of arriving immigrants. So, with the growth of agency, the growth of agency came about at the same time with the growth of public health. And what I've discovered is that most of the growth in agency is a response to public health issues. Here's a quarantine station on Long Island, 1871. National Quarantine Act transfers that function from the states, the different states, to the Federal Marine Hospital Service, now the U.S. Public Health Service. I mentioned the laboratory on disease, and then the Marine Hospital assumes responsibility for medical examination of immigrants. And here's an example at Ellis Island, where we're looking at our new Americans from Europe, and most of us on the East Coast, myself included, we always think, oh yeah, it's Ellis Island. Well, in San Francisco, there's Angel Island, and that's where new Americans arriving from Asia had their entry into the United States, their medical exam, quarantine, if necessary. And Ellis Island and Angel Island are just 2 out of 50 ports where immigration centers were established by the U.S. Marine Hospital Service. Didn't end there, but still continued with, even in the 20th century. Here's an example. Both in 1947, a foreign quarantine officer inspects the plane and sprays it with insecticide before allowing passengers to disembark. There's a fear of malaria and yellow fever from countries where perhaps these diseases were not controlled. And in the bottom, passengers from Cairo debarking at, it says Kennedy International Airport. It actually was called Idlewild. And they were being led to a quarantine room for questioning, possible examination, and then released into the country. Growth of agency continued. Pure Food Drug Act, Bureau of Indian Affairs, NIH was created out of the Public Health Services Hygienic Lab, Social Security Act, Federal Food, Drug, and Cosmetic Act. And then in 1939, the Public Health Service is transferred to the newly created Federal Security Agency, bringing together related activities such as health, education, and social insurance. And then in the 50s, this became health, education, and welfare, and then later education was separated and has its own cabinet department, and Health and Human Services became its own cabinet area. Hospital Construction and Survey and Construction Act, I'd already mentioned. Migrant health. Again, all of these programs have caused agency to be either developed, enhanced, separated out, and sometimes combined. We continue to see the growth of agency in the 70s, and something has happened a little different here. In 1975, we have something called the National Health Plan and Research Development Act. And this was an attempt to slow down the growth of healthcare in the United States by requiring any entity, usually a hospital or a private group that wants to provide health services, if any entity wants to expand the number of hospital beds or provide new services, they had to apply, they had to get permission from a health service agency, which was a combination or a board made up of community and elected officials to review requests for developing health services to make sure we weren't duplicating. The original threshold on that used to be like $200,000 or $250,000. Eventually it was raised up to $750,000 or $1 million, depending on the state. So that's that's one of the first attempts we have at trying to control healthcare cost. There is another one which I left off, but you'll see it later, and that's the HMO Act of '73. In 1977, Healthcare Financing Administration was created. Now it's called Center for Medicaid Medicare Services, CMS, because we're looking at Medicaid and Medicare, which essentially is serving at least a fourth of the population, of the U.S. population. Department of Health Education, we already went through that. Agency for Health Care Policy and Research, an attempt to look at health as a service and whether or not it is efficient and effective in its approach. So in looking at all these laws, I said, well, what about these other areas such as professional regulation, cost control, or commerce? Professional regulation really has been quite limited. One of the earliest was New York City adopting licensure requirement for physicians to practice medicine. One of the problems was it was not retroactive, so people who were practicing medicine before that who had questionable credentials, if any, were still allowed to practice. American Medical Association, established in 1847. First supervising surgeon or surgeon general, 1871. National Conference of State Medical Examining and Licensing Boards. So it's just the dawn of the 20th century that we have physician licensing in most states. Early 20th century Flexner Report, which was a critique of American and Canadian medical schools, and as a result of that, several medical schools actually closed because, according to the report, they weren't producing good results in their graduates. And essentially, it caused many medical schools to align themselves with universities and change their curriculum. American College of Surgeons formed, Joint Commission was established in 1952, surveying hospitals primarily, and then when Medicaid and Medicare came along, hospitals had the choice. You can be surveyed by the federal government to be eligible for participation in Medicare and Medicaid, or you can be surveyed by the Joint Commission. So, and that's, when it comes to professional regulation, that's it. There's other pieces of regulation that regulate the profession, but they are pieces. But, big, broad, sweeping legislation or practices or organization by private entities, this is about it. The impact of healthcare delivery policy on commerce. Again, we're going back to those early laws on taking care of the seamen and the marine hospitals. It's not only taking care of human cargo, but it's also an economic necessity to keep commerce going, to make sure that you have a marine force, a merchant marine force that's able to transport the goods. New York City adopts licensure requirements. That can be looked at as a restraint of trade. President Lincoln appoints a chemist, Department of Agriculture. So now we're, bringing together the forerunner of the Food and Drug Administration. That has an impact on commerce. Who can sell what kind of labels you have to have. First Blue Cross plan established, great impact on commerce. It developed private health insurance. Social Security Act told the country that it's okay to have the government take care of retirees and to provide a pension. And later, Medicaid and Medicare were amendments to that. Release of the Surgeon General's report on smoking and health, the federal cigarette labeling, so that had an impact on the cigarette industry. Medicaid and Medicare certainly had an impact on the healthcare industry. If it did anything, it accelerated the development of hospitals, nursing homes, medical practice. And then in 1973, we're beginning to look at ways of hopefully reducing the amount of cost and the increase of healthcare cost. And these National Health Plan and Resource, Certificate of Need law I mentioned. Massachusetts mandates comprehensive universal health insurance and Medicare prescription drug. All these have an economic impact on the private commerce. And lastly, I looked at cost control. And I did that because between 73 and 97, there was 5 legislative attempts to control healthcare costs in several events. And that is sandwiched in between legislation which increases healthcare, increases availability of healthcare, puts more money into the system from the federal level. So after, in 46, once we built up the hospital infrastructure, and in 65, we funded with new insurance-like programs from the government for the elderly and also for the poor. We realized that healthcare, the cost of healthcare is increasing quite rapidly, and so we implement the Health Maintenance Organization Act in 73, which is essentially developing demonstration projects to see if HMOs will work. And obviously in the 1980s it took off as the main way of, or managed care as the main way of delivering health care. Health planning in order to reduce the proliferation of healthcare development. Healthcare Finance Administration created to oversee Medicare and Medicaid. Tax Equity and Financial Responsibility Act, essentially in 82, DRGs for hospital reimbursement was developed for Medicare reimbursement. In other words, instead of paying hospitals based upon their cost, we're going to, now that we have several years of cost data from hospitals since 1965, what we're going to do is we're going to have a level payment. We're going to have a payment per episode of care, per admission. Later in 1977, that was also applied to nursing homes and home health care agencies. And why that happened was in 95, we realized that the Medicare Part A trust fund was insolvent. And so now we're in this period of, trying to balance the federal budget, realizing healthcare is a big part of it, and how we're going to do that. And then we implement the Medicare Prescription Drug Act, which impacts commerce, and it also provides a benefit to Medicare beneficiaries for prescription drugs where there once wasn't. And then the Affordable Care Act, which will, when it's finally fully implemented, if it ever gets out of the Supreme Court, will provide health insurance to additional Medicaid recipients and put in comprehensive health care reform. So in looking at all this, what I see is that early on the U.S. healthcare policy was pretty much responsive to public health needs, and before we had knowledge of health and disease, vaccination, before hospitals were places to go to get cure, we were handling much of this on our own in the public sector through public health requirements by government. So what does all this mean? This is where we started. Did we end up here with the Norfolk Naval Hospital? I think what we ended up with is government-sponsored health insurance. The government's always been, since before the country was incepted, we've had some influence with government health insurance for merchant marines and through the armed forces. And it spread to Medicare, Medicaid, veterans of wars, and also military personnel through TRICARE. Through this arrangement, you have at least a fourth to almost a third of the U.S. population covered by some government health plan. And it's been that way pretty much for the past 50 years. So what has changed? What has changed is we have government-inspired health insurance. The government, through their demonstration that managed care can save money, private health insurance companies picked up on that as well, and now it's really part of our private health insurance plan as well. So I think we've come full circle. I don't see national health insurance being coming anytime soon, particularly with budget considerations. And I don't, and I see the United States and the legislature and the Congress, even though their campaign speeches are on national health insurance, and we've had national health insurance debates since the beginning of the 1900s. It never comes to fruition because of the cost of it, and this feeling that healthcare is a private responsibility, going back to the English Poor Laws, where parents are responsible for their children, and children are responsible for their elder parents. And before I open up to questions, I do want to acknowledge these two sources where I got a boatload of information of health policies, timelines, and also thank Lapis Library, in particular Megan Besaw, who has done a lot of footwork in gathering a lot of this information for me. So at this point, I would like to take questions if anybody has any.
I just had a question for you about professional regulation. You showed that there was almost a century where nothing happened. Isn't that because the states pretty much took over that right of licensing and controlling professionals? Hence, you don't see anything happening at the federal level.
That's correct. And that's one of the, I guess, the benefits of a federation government is that we can devolve these kinds of activities to the states. Also, the medical community was very instrumental in making sure that happened, and because it just worked out better that it was of local concern, and at the time medicine was becoming nationalized. It was still pretty much a regional ability. I mean, there was a time where cardiac surgery in Boston was a lot different than cardiac surgery in Chicago, basically because you had maybe one or two people in each city that were the preceptors, for those programs, and so they kind of put their individual mark on that. Thank you.
I was surprised that there wasn't anything following the Civil War. There's reflections from the Revolutionary War and after World War I, but I was surprised that there wasn't really anything following the Civil War.
Let's see if I can see the whole gestalt here. Pretty quiet. It's pretty quiet now. There's my bias. I selected this from some 30 pages of material, and then the author who was writing on health policy self-selected too. So I don't think we had a silence of activity, but it just didn't seem to be a whole lot of a health policy of a national level going on during that period.
The other thing that occurs to me might be if you're going to cover the people who were fighting for the Union and therefore discriminating against the people fighting for the Confederacy, or including them both, that itself might have been such a huge debate that nothing really happened.
Well, that's true. I mean, if you look at colleges, universities, large institutions of the day, they served as military hospitals, during the Civil War. And what came out of the Civil War was pretty much battlefield medical advancements. How to better amputate a mangled ankle at this point. And with any war, there's an increase in medical technology and battlefield medicine technology.
Thank you. That was a very, very interesting talk, and I was struck by the way in which you began by talking about the English Poor Laws and their sort of pervasive, ongoing effect, as it were, in the background. Now, one of the features of the English Poor Laws were the laws of settlement, right? So the idea that each locality, each parish vestry, really, was responsible for its own poor. So you then had a problem if your population was mobile, right? Where did responsibility lie? You had to send people back in some way to their parishes. Is one of the reasons why that system sort of was subjected to a series of reforms. And I wonder about the development of the U.S. economy, that really that's the context in which we have to see this, that you have a series of these very localized systems which take up the lion's share of whatever is going on. But then when you have an ever more homogenized, integrated national market, and I'm just talking in general national economy, you then have the problem of economies of scale and challenges, and this is even before you start talking about external national challenges like wars. Mm-hmm. So I wondered, first of all, do you see a correlation with straightforward economic growth? I mean, can you actually sort of correlate that in any systematic way? And then secondly, I wonder if you could talk a little bit about this tension between national efficiency, to use the language of the early 20th century. Oh my God, all our conscripts, they're suffering from dreadful diseases, and there's a public health issue there, so we have to deal with their vaccination, public health issues, or volunteers, not necessarily conscripts. On the one hand, versus this sort of notion of rugged individualism that you talked about. Is there that ongoing tension in American life between this notion of an efficient, homogenized national market, maybe tracking economic expansion on the one hand, then on the other hand, you have this moral notion of individualism that you talked so interestingly about?
Yeah, thank you. On your first point, the development in the United States was so spread out that healthcare was a local issue, and what became a national issue was defense and commerce. And you can see why the seaports were protected from disease and invasion. On the second point. The debate has been going on for some time, and a lot of it has to do with the way we grew as a country. A lot of it has to do with the way medicine is practiced, and I think it's only begin in the past 20 years. We're looking globally at how did other countries do this and we didn't. And other countries, have a higher, tax. The citizens are taxed more. You get more benefits, And there's also for example, in Germany, you have a system of guilds. And the guilds were essentially unions, and they provided the health insurance. They provided the social welfare. England was looking at social welfare even before World War I. In the I think it's called the beverage model of social welfare was enacted. The United States, we have this romantic idea that we're still on, the prairie, and that we're self-sufficient. And that's going to change as all the interstates get connected, or it has changed. We just haven't realized it yet. So, thank you.
I'm not quite sure how this question fits into what you said, but I'm curious in terms of the protective health or preventive health, and in the different kinds, particularly, I guess, in the early 20th century on, with the discovery of the different vaccines and so forth. How does policy fit in where you have tons of people who are prone to polio and whooping cough and measles and those kinds of things? How was policy enacted to ensure that everybody across the board had access to the vaccines and the things like that? Was that handled primarily through public health, or is there another strand of legislation that protected and safeguarded?
It was administered through public health. At the urging of public health officials, legislation was created to mandate, vaccination of smallpox, to hurry up the licensing of the Salk polio vaccine. And the public health service is, they can close anybody down. They have this authority, from Congress to take care of the nation's population from a health standpoint. And I think that goes all the way back to, the seaports and protecting the health of the seaport and the mariners, and then separating the two if necessary, in order to protect, the public health.
But were the costs primarily covered through the government, through local government, or through the federal government to ensure that it was a pervasive program and that everybody got it regardless of economic circumstances?
In the 20th century, it was certainly funded through government grants to the states to provide vaccine and vaccination. So.
Anyone else? Well, in that case, thank you very much for speaking.
Thank you. Yeah.